Picture this: a woman named Margaret. She's 74 years old, retired, still drives herself to church every Sunday, still does the crossword in ink because she trusts her own mind. She goes into the hospital on a Wednesday because she's been feeling dizzy and short of breath. Nothing sudden, nothing violent. Her own doctor tells her to go in and get checked, just to be safe. She feels reasonably calm walking through those doors. The staff are gentle with her. The forms are routine. She signs them because that's what a responsible person does when a professional hands you a clipboard. 3 days later, Margaret goes home. She feels steadier. Her family is relieved. And then, roughly a month after she's discharged, the envelopes begin to arrive. One is from a physician she never spoke to, a specialist who reviewed her case from somewhere else in the building and happened to be outside her network. One is from the hospital itself for the entire 3-day stay, and it's far larger than she expected because it turns out Margaret was never officially admitted the way she believed. She was placed under something called observation status. And because of that single word on a form she never saw, Medicare will not cover the follow-up care her own doctor recommended. Margaret did nothing careless. She asked polite questions. She cooperated with everyone. But no one sat her down and explained the 5 things that could have shielded her from all of it. And by the time she pieced together what had actually happened, the window to challenge any of it had quietly shut. My name is Dr. Ryan Foster. I've spent more than 2 decades working specifically in senior health. And what I'm going to walk you through today are those exact 5 things. 5 hospital and Medicare traps that catch older adults every single year. Not because they're foolish, not because they weren't paying attention, but because nobody explains the rules plainly before the moment those rules start to matter. Stay with me all the way through. Trap number 4 is the one almost nobody thinks to ask about until it's too late. And trap number 5, the one about how the hospital officially classifies you, is the single most financially consequential thing I discuss anywhere. But it only makes real sense once you understand the 4 traps that come before it. If this channel is new to you, take a moment right now and subscribe. This is what we do here. Calm, clear, practical guidance for adults who want to understand the system before the system starts making decisions on their behalf. Let's get into it. Before I get with the 5 traps, I have to hand you one framework first, because without it, the individual traps won't fully click together. I call it the assumption gap, and it's the reason Margaret's story repeats itself thousands of times a day across this country. Here's what genuinely changes about your relationship with the healthcare system after you turn 65. 3 things specifically. First, the rules get more complicated, not simpler. Most people assume that once they're on Medicare, coverage becomes clean and predictable. The truth is nearly the opposite. Medicare's rules around hospital admission, observation status, and the care you receive afterward are among the most tangled in the entire American healthcare system. What you don't know here genuinely comes out of your own pocket. Second, the paperwork you sign carries far more weight than you realize in the moment. Admission documents at most hospitals contain financial language that patients almost never read and that staff almost never explain out loud. Signing without truly understanding can legally shift financial responsibility onto you for costs that might otherwise have been challenged. Third, and this is the one that ties everything together, hospitals and insurers operate inside a system built around their own interests, not yours. I don't say that to make you fearful or cynical. I say it because that's simply how the incentives are arranged. And understanding that arrangement is the first step to protecting yourself inside it. So the assumption gap is the distance between what most seniors believe their coverage includes and what it actually covers under very specific conditions. Every single trap on today's list lives somewhere inside that gap. Hold that framework in your mind as we go through each one. Now, I want to ask you something honestly. Think back to the last time you or someone you love dealt with a hospital stay or even a single trip to the emergency room. Do you remember how quickly the paperwork appeared? How fast someone slid a clipboard in front of you and pointed to the line where you needed to sign? How little time there was to actually read anything, let alone stop and ask a thoughtful question? Almost everyone I talk to describes the very same experience. You're focused on the health problem in front of you. You trust the institution because these are professionals. You sign what they hand you, and you assume that signing is simply the correct and expected thing to do. Nobody quietly pulls you aside and says, here are the 5 things you should ask before you agree to anything at all. If any of that feels familiar to you, then this video was made for you specifically. Here's what I need you to understand before we go one step further. The financial and coverage disasters that so often follow a senior's hospital stay are not inevitable. They are, in the great majority of cases, preventable, if you simply know the right questions to ask at the right moments. The rules already exist. The protections already exist. federal law hands you real rights inside that hospital, rights that most people never use purely because no one ever told them those rights were there. That is what today is truly about. Not fear, not doom, just practical knowledge that puts you back in a driver's seat of your own care. Before we go deeper, if you'd like a written guide that lays out these protections and questions all in one place, I put together a free resource, and you'll find it linked in the description below. It's called the Longevity Guide, and thousands of people in this community are already using it to prepare themselves and their families. Go ahead and grab it now and follow along with me. Let me explain something about how hospitals and insurers actually process you as a patient. Because once you see this clearly, all 5 traps snap into focus. When you arrive at a hospital, 2 entirely separate systems switch on at the very same moment. The first is the clinical system, the doctors, the nurses, the people focused on treating your body and getting you well. The second is the administrative system, the billing, the coding, the classification, all focused on how your stay gets categorized for payment. And here's the part that catches people. These 2 systems do not always talk to each other well. The category your stay gets assigned to, often within the very first few hours of your arrival, can quietly determine tens of thousands of dollars in coverage outcomes down the line. Think of it like checking into a hotel. Whether the front desk logs you as an ordinary guest or as a conference attendee changes which services are included in your nightly rate. You're sleeping in the same room. You're eating the same breakfast, but the billing behind the scenes is completely different, and nobody at that front desk is obligated to explain the difference unless you specifically ask. That is precisely the system you're walking into every time you or someone you love enters a hospital. A report from the Office of the Inspector General found that Medicare patients placed under observation status rather than being formally admitted faced hundreds of dollars more in out-of-pocket costs per hospital stay compared to those admitted as inpatients. That isn't a mistake in the billing office. That is the system operating exactly the way it was designed to operate. Now, here's what I've found across more than 20 years in this work. There are 5 specific traps inside that system that seniors run into most often and most preventably. I've ordered them deliberately, from the most common to the most critical, so you know where to focus first. The final one affects more people than anything else on this list, and its financial consequences can be genuinely devastating. But you need the first 4 to fully appreciate why. Let's begin. Trap 1. Out-of-network surprise bills. When Barbara was 68, she had solid Medicare coverage and a supplemental plan she'd faithfully carried for years. She went in for a planned cardiac procedure at a hospital that was firmly in her network. She even asked the right questions ahead of time and confirmed that her surgeon was in network. 3 weeks later, she opened a bill for over $4,000 from an anesthesiologist she had never met and never chosen, someone who assisted during the procedure and simply was not part of her network. Most people assume that if the hospital and the main physician are in network, then everyone touching their care must be in network too. That assumption is flatly wrong. Hospitals routinely rely on contracted specialists, anesthesiologists, radiologists, pathologists, surgical assistants, who each maintain their own separate network agreements. These providers can bill you independently, and the hospital's in-network status does not automatically extend to cover them. Now, the No Surprises Act, which took effect in January of 2022, offers federal protection against many of these bills. Under this law, for most planned procedures, out-of-network providers cannot bill you more than your in-network cost-sharing rate without your explicit written consent given in advance. The key word there is explicit. If you sign a general financial consent form without realizing it contains a clause waiving your No Surprises Act protections, that waiver can hold up against you. So here's the practical guidance. Before any planned procedure, ask the hospital, in writing, for a list of every single provider who will take part in your care. Ask specifically which of those providers are inside your network. If any of them are out of network, ask whether you can request an in-network alternative instead. And if anyone asks you to sign a document consenting to out-of-network billing, read that clause slowly and carefully before your pen ever touches the paper. The common mistake is assuming a general consent form carries no specific financial teeth. It very often does. Any form containing the phrase financial responsibility or non-participating provider deserves a careful, unhurried read before your signature goes on it. And if you do receive a surprise bill after a procedure and you believe the No Surprises Act applies, you have the right to dispute it. The federal dispute process runs through CMS, the Centers for Medicare and Medicaid Services, and your insurer is required to give you information on how to start it. Within the first 30 days of getting a bill you believe is wrong, contact your insurer and request an itemized statement. Document every phone call, every name, every date. The earlier you raise the dispute, the more options remain open to you. Now, Trap 2 catches people in a completely different moment. Not when the bill arrives, but when the hospital tells you it's time to go home. Trap 2. Premature hospital discharge. Harold was 74. He'd been admitted after a fall that left him with a hairline fracture. After 3 days, a hospital administrator, not his physician, informed him that his insurance had approved his stay through the following morning and that he should plan to head home. Harold felt genuinely unsteady. His pain still wasn't well controlled, but he assumed that if the insurance said it was time, then it must be medically appropriate. He went home. He fell again 2 days later. Here's what Harold never knew. Medicare beneficiaries have the legal right to appeal a hospital discharge decision before leaving, the very same day if necessary. This is not a complaint form, it is a formal federal right. It's called a Quality Improvement Organization appeal, or a QIO appeal. Every Medicare patient must be handed a written notice called the Important Message from Medicare, which explains this exact right before discharge. If you were never given that notice, the hospital's out of compliance. A study from the Commonwealth Fund found that roughly 1 in 5 Medicare patients is readmitted to the hospital within 30 days of discharge, and premature discharge is one of the most frequently cited contributing factors. And readmission carries its own costs, its own risks, and its own tangle of coverage complications. So here's the practical guidance. If you or a family member feels that discharge is happening before it is medically safe, request a QIO appeal immediately. You don't need a lawyer. You don't even need your doctor to agree with you. You call the QIO, and that phone number must be printed right on the Important Message from Medicare document, and you request a review. Medicare will pay for your continued stay while that appeal is being reviewed, and the hospital cannot discharge you during the review period. The common mistake is waiting until you're already home to raise the concern. Once you walked out those doors, the process changes and your options narrow considerably. The time to act is before discharge, not after. Quick pause here. Have you or someone in your family ever felt that a hospital discharge happened too fast? Drop a yes or a no in the comments below. In my experience, this is far more common than people admit, and the ones who successfully appeal are almost always the people who knew this right existed before they ever needed it. Trap 3. Medication substitutions during your hospital stay. Ruth was 71. She took 4 medications daily, ones her doctor had carefully selected and adjusted over several years. When she was admitted for a knee replacement, the hospital swapped out 2 of those medications for alternatives from their own formulary, which is simply the hospital's approved list of drugs. Nobody asked her. Nobody explained why. She assumed the hospital knew best. After discharge, she experienced side effects she'd never had before, and she spent 2 full months working with her doctor to stabilize her regimen again. Here's what most people don't know. Hospitals keep their own formularies, their own approved drug lists, and when your regular medication isn't on that list, they will often substitute an alternative without any specific consent beyond the general admission paperwork you already signed. This is standard practice. It is also perfectly legal, but it creates real problems when the substitute behaves differently in your body, interacts with something else you take, or creates a difficult transition at discharge when you return to your original medications. A report published in the American Journal of Health System Pharmacy found that medication discrepancies at hospital admission affected a significant share of older adults, particularly those on 5 or more medications, and that these discrepancies were a leading cause of adverse drug events during and after hospitalization. So here's the practical guidance. Before any planned hospital stay, write out a complete medication list. Every drug, every dose, every frequency, including your over-the-counter medications and supplements. Bring that list with you when you're admitted. Hand it to your care team and ask them directly, will any of these medications be substituted during my stay? And if so, can you explain the reasoning and how we'll transition back safely at discharge? You have the right to ask. You have the right to bring your own physician into that conversation. The common mistake is assuming the hospital's pharmacy team's automatically coordinating with your regular doctor. In many cases, they simply are not. That handoff is your responsibility to start. This is not medical advice, and your specific medications and history deserve a real conversation with your own physician. But the habit of carrying a complete written medication list into every hospital encounter is one of the most protective things you can possibly do. Now, we're going to shift gears. What I'm about to cover next is the part of the hospital experience that most people never think about until it has already happened to them. These last 2 traps are where the real financial exposure lies. Trap 4. Financial responsibility forms buried in the admission paperwork. Most people know they'll be asked to sign paperwork when they're admitted. What most people don't know is that those documents often contain financial clauses that reach far beyond simple consent to treatment. Martin was 69. He was rushed in to the emergency department after a cardiac event. Understandably, he was in no state to read carefully. He signed everything quickly. Among those documents was a clause agreeing to be financially responsible for any charges not covered by his insurance, including charges arising from coverage disputes. 18 months later, when his insurer denied a portion of his claim, the hospital used that signed clause to pursue him directly for the balance. A 2021 analysis by the Kaiser Family Foundation found that more than half of American adults reported difficulty affording healthcare costs, and that surprise billing and unexpected out-of-pocket charges were among the most commonly cited sources of financial hardship. For seniors on fixed incomes, a single unexpected hospital bill can represent months of income vanishing at once. So here's what you can do. If you have any capacity at all to review the admission paperwork, or if a family member or advocate is beside you, look specifically for language about financial responsibility, assignment of benefits, and non-covered charges. You are allowed to ask questions before you sign. You are allowed to cross out or annotate specific clauses. Write, "I do not agree to this clause," next to any language that makes you uncomfortable, and initial it. This doesn't guarantee the hospital will honor your annotation, but it creates a documented record of your objection that can matter enormously in a billing dispute later. And if you're admitted through an emergency and truly cannot review anything in advance, you can request a copy of everything you signed once you're stable. And you have the right to dispute charges arising from clauses you were in no condition to review. The common mistake is assuming that because you signed something quickly, under stress, you have no recourse at all. That assumption is not always correct. Many billing disputes are successfully resolved after the fact, but they demand documentation and patient persistence. Now here it is, the trap that changes the entire conversation, and the one that connects directly back to Margaret's story at the very beginning of this video. Trap 5. Observation status versus inpatient admission. This is the most misunderstood and most financially consequential classification in all of Medicare, and I want to explain it clearly because the details here matter enormously. When you arrive at a hospital and a physician orders you to stay, you and your family will almost certainly assume you've been admitted as an inpatient. In a surprising number of cases, you have not. You may instead have been placed under observation status, a classification that means under Medicare's rules you are technically an outpatient receiving extended monitoring, even if you are lying in a hospital bed for several days. The practical difference is staggering. Under Medicare Part A, inpatient admissions cover your hospital stay and, critically, they make you eligible for follow-up rehabilitation coverage at a skilled nursing facility, provided you meet the 3-day inpatient stay requirement. Under observation status, none of that applies. Your stay may be billed under Medicare Part B instead of Part A, often at a higher out-of-pocket cost, and you are not eligible for covered skilled nursing facility care, no matter how many days you actually spent in that hospital bed. A report from the U.S. Government Accountability Office found that the number of Medicare beneficiaries placed under observation status for more than 48 hours climbed dramatically over an 8-year period, and that many of these patients had no idea about their classification until the bill arrived. The consequences for those who needed rehabilitation afterward were severe, with some patients facing skilled nursing costs of hundreds of dollars per day that Medicare would not touch. Now, the Notice Act requires hospitals to notify Medicare beneficiaries in writing within 36 hours if they're under observation status rather than admitted as inpatients. That notification is called the Medicare Outpatient Observation Notice, the MOON. You are entitled to receive it. If you don't receive it, ask for it. So here's the practical guidance. Within the first 24 hours of any hospital stay, ask your nurse or care coordinator directly, am I formally admitted as an inpatient or am I under observation status? Write down the answer and write down who gave it to you. If you're under observation status and you believe your condition warrants inpatient admission, you or your physician can request a status review. Your doctor's clinical judgment about the right level of care carries real weight in that review. And here's what to do differently. Instead of waiting to find out at discharge, ask on arrival. Ask again after 24 hours if the answer was observation. If you're told inpatient admission requires authorization, ask who is responsible for pursuing that authorization and what the timeline looks like. The common mistake, and it is the single most costly one on this entire list, is assuming that if the hospital put you in a bed and kept you 3 days, Medicare will count those days towards skilled nursing eligibility. That one assumption has cost seniors and their families staggering sums in uncovered rehabilitation costs. The question costs you nothing to ask. The answer can change everything. Before I give you a 30-day action step, I want to leave you with something you can use at your very next hospital encounter or hand to a family member who might face one. I call it the Hospital Admissions Safety Protocol. 5 questions. Write them down. Put them in your phone. Give this list to whoever is most likely to be beside you in hospital. Question 1. Am I being formally admitted as an inpatient, or am I under observation status? Question 2. Can you give me a list of every provider who will be involved in my care today, and which of those providers are in my insurance network? Question 3. Will any of my current medications be changed or substituted during this stay, and can my own physician be consulted before any changes are made? Question 4. What are my rights if I believe I'm being discharged before I'm medically ready to leave? Question 5. Is there anything in the paperwork I'm being asked to sign that makes me financially responsible for charges my insurance may not cover? Any good patient advocate, social worker, or physician will genuinely welcome these questions. And if the response you receive somehow makes you feel that asking was inappropriate, well, that tells you something important too. Here is your 30-day action step, and I want to make this specific, because vague intentions never translate into real protection. This week, not in 30 days, this week, create what I call a hospital readiness file. It takes about 20 minutes. Write down every medication you take, the dose, and how often. Add your primary care physician's name and direct phone number. Add the name and phone number of one family member or trusted friend who can advocate for you if you can't advocate for yourself. Write down your insurance information, including your Medicare number and any supplemental policy details. And write down these 5 questions from today. Put that document somewhere you can grab it quickly and tell the person you listed as your advocate exactly where it is. That file is your protection, not because anything bad is going to happen, but because the people who navigate hospitals most successfully are almost always the ones who were prepared before they ever needed to be. Check your file in 30 days and update anything that has changed. I want to close with something I think about often in this work. There is a real difference between a healthcare system designed to treat illness and a healthcare system designed to protect the person. After 65, navigating both of those at once requires more knowledge than most people are ever handed. The traps we talked about today are not the result of malice. They are the result of a complex system that was simply never built with the patient's financial protection as its first concern. The best patient advocates I've ever encountered, and I've worked alongside a great many, are almost never the loudest or the most combative. They're the most prepared. They ask calm, specific questions. They write things down. They know their rights before they ever need them. That is what you now have. You know what observation status is. You know what the No Surprises Act protects you from. You know you have the right to appeal a discharge. You know to read the paperwork before you sign it. And you know to carry your medication list every single time. In more than 2 decades, I have watched that kind of quiet preparation make a real, measurable difference in people's lives. You are not a passive participant in your own healthcare. You are a participant with rights. And today, you know exactly what they are. If this gave you something useful, subscribe. That is what this channel is built for. Calm, real, practical guidance for adults who want to understand the system before the system makes decisions for them.